So we had a phone call from Mr. Simpson, who you've upped his dose from 7.5 to 15 milligrams. You doubled it because his pain was really unresponsive to the 7.5. And he's using it 10 times a day, which is a total of 150 milligrams in 24 hours. And it's bringing his pain from a 7 to a 4. And he says he can function at a 4. He can get to work, he can take care of his kids, he can take care of himself. What do you do next? So do you want somebody having to get up multiple times in the middle of the night to take a medicine and basically having to clock watch to take pills every 2 to 3 hours? You want to switch him. I don't know, do you guys have access to long-acting morphine?
No, we don't.
All right, I'm going to skip this. But ideally, you would put somebody, instead of on a pill they have to take every 2 to 3 hours around the clock, a pill they can take every 8 hours that slowly releases the same amount of drug. So here's a situation where he comes in despite being on 300 milligrams of opioid around the clock and a rescue dose of 30 milligrams. He is in an acute pain crisis. And that happens when people are being treated for cancer. The pain does not always remain stable. And sometimes those pain crises are due to, for example, a pathologic fracture or a new metastasis pressing on the spinal cord. What do we do? So managing a pain crisis almost always involves using IV medications if you have them, because they work quickly. And you want to get somebody out of excruciating agony as quickly as you can. A subcutaneous dose takes 20 minutes to work. An IV dose takes 10 minutes to work. If you give a dose of the IV and you don't get much response within 10 to 20 minutes, you increase the dose by 100%. If there's a minimal or partial response to that dose, you increase the dose by 50%. So later on, he completes his cancer treatment, his chemo and his radiation, and gets better, and he tapers off his opioids over about a month. 2 years later, he returns with local bony metastases from his squamous cell carcinoma and severe pain. His primary doc gave him oxycodone, which is similar to morphine but slightly more potent, every 6 hours. Meaning his primary doc did not know that the half-life of the drug is 3 to 4 hours and gave him an incorrect interval. But he's been taking, in fact, 1 tablet every 3 hours to keep the pain tolerable. It's also causing a lot of itching. And he now has developed chronic kidney disease in the interim as well. So you need to put him on a new regimen that is both better tolerated when someone has renal failure, and may cause less itching. And in this instance, in America, we would switch him either to hydromorphone, which is dilaudid, or to a fentanyl patch dose, because both are better tolerated in people with renal insufficiency. If you don't have access to those drugs, you use the morphine and you just dose adjust more slowly and carefully. So he comes to the clinic and your student says that when he was in the room with him, he looked comfortable, but when you walk into the room, he starts grimacing, rubbing his shoulder inside and saying, "Can't you give me something stronger?" So what do we immediately assume? We immediately assume he's manipulating us for a higher dose because he looks perfectly comfortable when we are not in the room. And only when we come in the room does he evidence pain behavior. So this could be many things. He could have become tolerant to the analgesic effect, but as I said to you, that almost never happens in cancer. He could now becoming addicted and need higher and higher doses because he's got a true substance use disorder. Or we could be underdosing him, and so he's showing pain behaviors because we're not giving him the right dose or at the right interval. And in situations like this, sometimes we need to think about whether there's something we can add that might help as opposed to an increased dose of opioids. We may have to use an increased dose of opioids, but we may want to think about, for example, if somebody has bony metastases, corticosteroids can be very, very helpful by reducing the inflammation and the pressure on the bone. Radiation therapy can be helpful for bony metastases by reducing the size of the met and the pressure that it's putting on the bone marrow and the bone. If the person's pain sounds like more nerve pain as opposed to other types of pain, numbness and tingling, burning, you might want to use a medicine that's more appropriate for nerve pain, like a tricyclic antidepressant or gabapentin. And then there's also the issue of despair, existential distress, depression, feeling like God has abandoned me, feeling like one is being punished for past sins, and addressing those things is also important at the same time as the patient's report.